Okay. Hello, everyone. Hi. Great. So it's lovely to see so many of you joining. We're just waiting for a few more presenters to join in because there's a few issues with Teams. But I'm gonna start introducing this event. So thank you so much to all the speakers and the audience for joining in. This is the latest EUHealthGov event. So for those who do not know us, EUHealthGov is a research network funded by the University Association for Contemporary European Studies and the Erasmus Plus program of the European Union. And it is coordinated by Dr. Mary Guy from Liverpool John Moores University and myself, Dr. Charlotte Godziewski from City University of London. So this event is part of a quarterly webinar series that we run on topics related to EU and health. And if you would like to hear about future events, you can follow us on Twitter at EUHealthGov or subscribe to our mailing list via our website, euhealthgov.org. I would also like to make everyone aware that the event is being recorded and will be made available via our website in the coming weeks. Right, now to the main bit. So today we have a very special event and I'm really honored to have been part of it. We are launching the publication of a special issue on the political determinants of health and the European Union, which is now available as advanced publication on the Journal of Health Politics, Policy and Law website. Thibaud will tell you more about how this project came about in a second, but right now I'm going to try and keep it as brief as I can because we have a program packed with fantastic presentations. So what I'm going to do is just very briefly introduce the speakers and do a quick run through the program. So let me just share. I've got just one slide here that I wanted to share. So yeah, the guests, is this big enough that you can see it or is it quite small?
Yeah, good.
Okay, good. Yeah, so the guest editors, Thibaud, Ellie, and myself, and almost all of the wonderful authors who have contributed to the issue are here today, and they will present their research articles for about 5 minutes each. So we're going to kick off with Thibaud Deruelle from the European Social Observatory with a guest editor introduction. We will then have Florian Tille from the European Observatory on Health Systems and Policies introduce a framework for studying EU health policy using the political determinants of health. This will be followed by a presentation by Mechthild Roos from the University of Augsburg on forced migrants in health and the EU. We'll then have Eleanor Brooks from the University of Edinburgh talk about the EU better regulation agenda and the impact that this may have on EU health policy. We'll then have Alexandru Moise from the European University Institute talk about healthcare privatization and population health in Europe. Mary Guy from Liverpool John Moores University will then talk about EU competition policy and solidarity as a political determinants of health. Matilde Ceron will talk about the whole framework of EU economic governance and the impact this has on health inequalities in the Eurozone. And then I will briefly talk about an article that I co-wrote with Simon Rushton from the University of Sheffield. We'll be talking about health security and the new HERA institution. We'll then have Ashley Fox from the University at Albany, State University of New York. She will be talking about the link between redistribution, welfare generosity, and health. And then Benjamin Ewert from Fulda University of Applied Sciences will be talking about the politics around the Nutri-Score and front-of-pack food labeling. And then we'll have Emilia Szyszkowska from Warsaw School of Economics. She will zoom in onto one EU member state, namely Poland, and look at the healthcare system in Poland. And then we'll wrap it up with guest editor concluding remarks by Eleanor Brooks. And then we'll hopefully have roughly 25-30 minutes for Q&A. So as you see, quite the packed program. I've put the link where you can find all the full articles online on the slide. But yeah, for now, without further ado, over to you, Thibaud. And let me just stop sharing.
Thank you very much, Charlotte. Hello, everyone. It's absolutely delightful to see so many attendees and so many presenters as well. So I'll be very brief because I want to let the papers shine. I just want to explain a bit the initial idea and how we came to do this special issue. So first, why political determinants of health? There are already a few models that some of you are probably very aware of, whether it's social determinants of health, commercial determinants of health. And we thought that by bringing the politics label into it, perhaps we could be contributing in adding to those models. For instance, when we talk about social determinants of health, very often politics and power are kind of left out of the equation. When we talk about commercial determinants of health, often there is a lack of, how can I say, interest for agency versus structure dynamics, for instance. So looking at the political determinants of health, we didn't think that we would embark on a journey to replace existing models or anything like this. Really, our idea was more to have some sort of unifying concept, something that would bring things in a more holistic manner and could bridge also disciplines such as public health, health policy, global health, sociology of health, welfare inequality, taxation, all those kind of aspects. So this concept of political determinants of health, at first, and that was the purpose of embarking on this journey, we didn't have a very precise idea of how to delimit it. So political determinants of health, we were thinking, okay, perhaps we will talk about different levels of governance, different systems, different institutions, different power disparities, different interests, even different cultures when it relates to health or other thing. This concept would be useful to discuss the impact of social justice on health and especially population health, but also the impact of public trust, for instance, on institutions. So we had basically the embryo of a concept, and we decided to focus on the why, because first of all, we are a community of people who study the EU quite closely when it comes to health. Second, by talking about the EU and Europe, we of course include member states, and today you will also have presentations that include political determinants of health within member states. And finally, the EU is a fascinating case for this, because if the goal is to uncover determinants of health, and in that case, political determinants of health, well, the EU, with this sort of reduced competencies, very trickle-down competencies when it comes to health, well, it's a fascinating case because we'll be able to go see how it matters to health in different policies, whether we're talking about fiscal policy, social policy, economic policy, all those kind of things. And by choosing the EU, we allow ourselves to dig deeper into very discrete areas, at least discrete when it comes to health, but those discrete areas have tremendous impact on health, as the different studies you will be presented today will show. So we had this call for paper. We organized a workshop in London in spring 2022, and our call was really a bottom-up delineation. We asked our fellow researchers to engage with the concepts without over-defining it, and hoping that they would really engage with it, helping to conceptualize. As just a little, maybe a way for you to look at all those presentations, eventually we found two things of importance: the multi-level governance aspects of it, and of course things that relate to politics and power. So I'll let you keep those two things in mind as the presentation will go on. Ellie will be bringing everything at the end together, and we discuss those two themes, among other things. And for now, I give the floor back to Charlotte. Thank you very much, everybody.
Great. Thank you so much, Thibaud, for this really clear and great introduction. So I think, unless I made a mistake, I think Florian is still has not joined yet because he's caught up in another meeting. But what I would suggest is then we perhaps move on to Mechtild's presentation, and then we will go back to Florian later. Mechthild, would you like to, I'll leave the floor to you.
Thank you so much. I do have a very tiny PowerPoint, and we didn't check now if that works. So I will just, sorry, I just improvise. Here we go. Do you see the PowerPoint?
Yes, perfect.
Very good. So my paper was, I think, the first empirical, or one of the empirical studies in this great special issue, which I'm very grateful to be part of. I think it's very, very important. So thank you very much to the guest editors for this initiative and for bringing us together. I already learned loads in the process of all the workshops and kind of exchange we had. And my paper focuses on the EU itself as a political determinant of health, with a focus on two dimensions of its active role as a political determinant of health and as its passive role of determining health in the EU member states. And I'm focusing on one specific group in society, one particularly vulnerable group, namely forced migrants. The question my article seeks to address and to answer is the following: how and with what purpose was the EU used as a point of reference in German draft legislation on forced migrants' access to health and healthcare under the impression of recent crises in the areas of migration and health? And to kind of this very long question to break it apart a little bit, what is important, I believe, in terms of what my article focuses on is, again, the group of persons I'm looking at. This is a very vulnerable, very marginalized group that is prone to politicization and has been increasingly so, particularly in recent years of polycrisis in the EU, if you wish. And the crisis focus in my article focuses on a whole range of crises, starting with the so-called migration administration crisis of 2015 to 16 to 17, and then including also COVID and Russia's war against Ukraine. And these crises increased politicization of both migration and health across the member states, including also in Germany, which is my case study. I chose Germany as a case study, not only because it's the largest EU member state, but because it has this norm setter role in EU migration and health policy. It has been very actively advocating an extension of EU competences in both the areas of health and migration in recent years. And at the same time, its national legislation has not shown the same picture. And this is also what I'm interested in my article. And so my data set is a number of draft acts on or regulating forced migrants' healthcare access, health access in this period 2015 to 2022. That's the kind of my time frame. And in these draft acts, again, I look at two sides of the political determinants of health coin, if you wish, on the active role of the European Union and on the passive role of the European Union in determining the health and healthcare access of forced migrants. The active role might be... Yes.
Just real quickly, I'm just noticing that we cannot see you change the slides. Could you maybe just put it on full screen? Really sorry to interrupt you.
Sorry, it is on. Maybe I'll go out of the sharing mode.
Okay.
I just speak to you then. Now you should not see the screen anymore. Is that correct?
Yes.
Okay, then I'll just take you through it. Well, myself in a way, without my PowerPoint. So the active role of the EU as determinant of health is pretty intuitive, I would say, and it pretty much covers the typical definitions of a political determinant of health. It's about the EU's role as standard setter by law and by policies, by norms and by rules that it gives, that are adopted at EU level and that are binding either legally or at least normatively for the member states. But I argue that there is a second role that we need to be aware of when we study the EU's role of determining health and healthcare, and that is the role of national policymakers, maybe even municipal level or regional level policymakers, in interpreting and in invoking EU norms, rules, policies, and also competences or even incompetences of the EU in legislation processes and in policy implementation processes. And what I found in my article is really that this passive role of the EU in determining forced migrants' health is much larger in the German case than its active role. So while we do find in the draft legislation and then also in the adopted legislation instances of harmonization of national law based on EU standards, based on EU legislation, and we find minimum standards that Germany needs to and wants to adhere to, what appears much more frequently are references to the EU when it comes to blame shifting, kind of scapegoat seeking, these kind of approaches of making the EU part of the argument why certain policies need to be brought forward. And this includes the EU's insufficient crisis response based on the attitude of national lawmakers. This is about the EU's inactivity in certain areas where more policy making needs to be done and needs to be led by the member states to be then transported to the EU level. And the German government, those behind those legislative drafts that I looked at, use the EU as justification for unpopular, for normatively questionable kinds of draft acts and policy measures that they want to propose if they feel like, yeah, again, they need a scapegoat and they need some other level to blame for and to put responsibility on when it comes to proposing healthcare measures and measures in terms of healthcare access. And so really, maybe as a final sentence, the question of increasing Europeanization in both these areas of migration and of health has not only forced national legislators to adapt legislation in order to abide to EU rules, EU laws, but it has also prompted governmental actors at the member state level to shift responsibility for policy reforms to the EU, even in cases where not all of these reforms would have been legally required, even where the EU really hadn't said anything about the areas in which policy measures were proposed. Maybe just so much from my part.
Thank you so much, Mechthild. Thank you, and sorry again for interrupting. Great. Let's move on directly to Ellie. Ellie, are you ready? Do you have a slide to share? Or
I have one slide to share, but I'll put it up in just a second. Can you hear me okay?
Yes.
Yes, I am having camera issues. I'm just going to leave it and maybe it'll sort itself out. I'm sorry. It's obviously our great day for technological everything working. Nevertheless, thanks so much for having me. It's really lovely to see so many people here and to be involved in being able to launch this this project that's been so much fun to work on. For my part just now, I'm going to say a few things about the paper that that is in the special issue by myself and the wonderful Catherine Lauber. Both of us are based at the Global Health Policy Unit at the University of Edinburgh. So our paper, what we took from the political determinants of health idea was very much at the upstream level. So we wanted to look at what was going on quite far above the sort of health policy, but also all of the ones around the edge that we know linked to the social determinants of health. So education and welfare and transport and social policy. We wanted to step really one place above all of those policies and look at what we describe as the meta-regulatory frameworks that shape the way in which those policies operate. So the case that we look at is something called better regulation. So better regulation is the EU's good governance framework. It's the framework that means that the EU conducts impact assessments of its policies, systematic evaluations of its policies, requires that it consults stakeholders throughout the policy process. And the approach we took to understanding how this framework could be affecting health is drawn from the literature on international trade and investment agreements. So specifically from this literature, we took the concept of regulatory chill, and that's a concept that's been used in the past to describe investor-state dispute settlement mechanisms. So these mechanisms by which companies can sue governments for policies that are designed to protect health but might impinge upon commercial interests in some way. We felt there was real mileage in that concept in terms of better regulation. We felt there was a lot to get out of that concept to try and help us to understand how a policy so far away from health, or seemingly so far away from health, might be affecting the way in which health policy is made. So that's the concept that we decided to borrow. If I share my screen, you should hopefully be able to see the sort of main graphic. Thanks, Charlotte. So this is the main graphic that's in the paper, just by way of illustrating how we've used the concept and what it's allowed us to do. So essentially, the paper maps the possible pathways by which better regulation might be shaping health policy making, and we identify 4. They're quite similar to the ones that are identified in the ISDS literature, and they can be divided into sort of 2 sets. So on the one hand, what we talk about is the way in which better regulation produces a response in policymakers. So that can happen directly by the enforcement of something like an impact assessment, which might delay legislation. It puts many more steps into the legislative process and slows the entire process down. But it can also happen in direct response to engagement by corporate actors. So we look a lot at how the structures of better regulation can be used by corporate actors, tying in quite closely to the commercial determinants of health literature in their efforts to influence the policy process. Then you've got a second set of pathways, a second 2 pathways that are what we would describe as anticipatory chill. So here we talk about how policymakers interpret and learn the ways in which better regulation operates, what it constricts them in doing, what it allows them to do, what it forces them to focus on, what it forces them to ignore. And here we talk a lot about sort of quantification of impacts, for instance. So the way in which if you push people to quantify impacts, that's going to push them to ignore one thing or another thing, and how the anticipation of that will cause policymakers to make decisions even before they've reached the point of being able to put their policy forward, that actually they know this isn't going to be received well, it's not going to make it through the process, so they're already sort of checking themselves before initiatives come forward. The second set of anticipatory chill comes sort of at the end of the process, so at the very last stage you see these feedback loops come into play, and here the idea is that the more you see this thing in action, the more you see better regulation shape the way in which policy is developed, you see corporate actors making use of it, you see senior political levels within the EU using it to constrict or to encourage even, that will become built into the process. So it's a slightly more sort of circular form of anticipation. But we walk through these 4 pathways. I think we're quite critical of the extent to which we're able to evidence them, particularly with the anticipatory chill. We talk quite a lot about the difficulty in evidencing that, because it requires us to know something about the way that individual policymakers think, and that requires them to be willing to tell us about that, which isn't always the case. So we do talk quite a lot about the possibility of being able to research these aspects of regulatory chill effectively, but we essentially put forward an agenda for how regulatory chill might be used to analyse the way in which this framework works. And I also think part of what we were trying to achieve was to say, well, look, if the political determinants of health are up at this upstream level, what are the links that we can make with some of the literature that already exists in areas like international trade? How can we draw on that, in line with what Thibaud was saying at the beginning about bringing together areas of work that already exist that we think might count as the political determinants of health, if you like, but don't necessarily all identify under that label just yet. So that's what we were trying to achieve roughly, and that's my 5-minute pitch of the paper. And I'm really looking forward to hearing the rest. It's already been super to hear from Mechthild and remind myself how many fab papers are in this issue. So thanks, Charlotte, for the space, and I'll pop back just at the end and try and fix my camera in the meantime.
Great, thank you very much, Ellie. That was exactly 5 minutes. Wonderful. Let's move on directly to Alex. Yeah, okay. You're muted. Okay, perfect.
All right, let me try. I also have a couple of slides. Let me try and share. Can you see my screen?
Yes, perfect.
Okay, great. So thanks again, Charlotte, Ellie, and Thibaud for organizing this and for all of your support during the process of writing and pushing these through. So this is a paper by myself and Tamara, who's also here. And what we basically do is we want to look at the political determinants of health inequalities. And specifically, we want to look at the effect that privatization reforms have. So we start from a political epidemiology perspective, which basically looks at how policies and politics impact direct population health. And specifically, we look at these privatization reforms. So what do we mean by privatization reforms? We mean reforms that, for example, introduce user fees, increase private insurance out of the insurance pool, privatize hospitals or outpatient clinics, or otherwise cut existing services or existing benefits in public systems. How do we do this? So we look at 36 countries from 1989 to 2019. We have an original data set of reforms coded for each country and every year. That was part of the Health Docs project. And we basically use this as our main independent variable. And we look at basically two measures for health inequalities. So this is silk data from Eurostat, country aggregates of basically survey responses. And we have these two measures. One is subjective health, so respondents answer how they feel about their health generally. And second, unmet needs, whether respondents say that they have unmet health needs due to a variety of reasons, including finance, waiting times, distance, and so on and so forth. And we basically want to look at whether privatization reforms affect these two outcomes, and then we want to see if it affects these two outcomes differentially by groups, and we look at different income groups and different education groups. So we basically want to see if privatization reforms result in increased health inequalities. So I'm just going to present two brief graphs from the results. So this shows our, let's say main results by just looking at the raw measure. So on the top you have subjective health status, and on the bottom unmet needs. And what you see in the coefficients there are the different time lags for privatization reforms. So we hypothesize that these reforms take a number of years to make a difference as people use the health system and they get implemented. We're a bit agnostic as to how long it takes, so we implement a number of lags, and here we show from the 3rd year to the 6th year lag. And what you can see is that, so for subjective health, the 5th year lag, and for the unmet needs, the 3rd year lag are significant at the 10% level, and some of the others come close. So what this tells you is that 3 to 6 years down the line from a privatization reform, you actually have an increase in the number of individuals who report declining subjective health and more unmet needs. But these are, let's say, population average effects. What we were actually interested in was to see are different groups of people affected differently, and we sort of discussed this in the theory section, that we actually expect these reforms to actually hit lower income and lower educated people more. Why is that? While privatization reforms can sometimes make health systems more efficient, they actually can impede access by user fees, which people might not be able to afford, or by efficientizing, closing down facilities where you don't have large population centers, and so on. So we actually expect this effect to be stronger for lower income, lower education groups. And we find some evidence for this. So on the left side, you see by education, on the left side you see the health, subjective health, and on the right side unmet needs. So what you can see on the top left is that for low income groups you actually have an increase in reported bad health, whereas for the high income group there's no difference. So privatization reforms don't make a difference for high income groups, and we see the same for education. So for the low educated you have an increase in reports of bad health, but you don't see this for the high education group. That's on the bottom left. And you see something relatively similar when you look at unmet needs. So again, for the lower income and lower educated groups, you have an increase in unmet needs, whereas for high education and high income, you have no change. So this leads us to conclude that these reforms do have an impact, a negative impact on the health outcomes of the population, but more specifically, it does so in terms of health inequalities, and it doesn't affect all groups equally. All right, so I'll stop there and thank you for your attention.
Thank you very much, Alex. Thank you. Let's move on to Florian. Florian Thiele, I saw you joined. Do you want to go next?
Yes, certainly. Very happy to. Thanks, Charlotte, and thanks for having us. And sorry about the slight delay from my end, but without much further ado, I'm happy to give you a very short pitch on our paper, which has the title "A Framework for Studying EU Health Policy Through a Political Determinants of Health Lens: The Case of the European Health Union." And again, the author team was Torben, Fischer, Nicole Mauer, and myself. Very briefly on the intro, so in the COVID context, the Commission had launched the European Health Union, EHU, with the aim of really building a mechanism that better coordinates member states' responses to public health emergencies as COVID obviously was. Well, some consider the strategy a potential turning point for EU health policy, especially against the backdrop of fragmented EU competencies in health and the deprioritization of health policy at EU level in the past. Others, however, had contrasting views, saying that it was really no big bang for EU health policy. So where did our paper come from? EU health policy research shows a certain imbalance between the analysis and evaluation of EU health integration and how it de facto affects the health of EU citizens. Well, we argued that the PDoH perspective helps to better understand the relationship between EU health policy outputs and implications for populations' health outcomes. So for our article, we developed a conceptual framework, and some of this might remember this from our workshop back in London, on how the EU health policy can be viewed as a PDoH and illustrate the early institutionalization of the EUH via 3 examples. Those examples were the joint vaccines procurement during the COVID-19 pandemic, healthcare reforms and investments in the Recovery and Resilience Facility, the RRF, and the European Health Data Space. Just really very briefly on this framework, and I won't do it justice now, but it's quite complex, and certainly I invite everyone who has interest to look at our paper and read through it more thoroughly. So central to our study, we integrated 2 dimensions into this framework to look across the different relationships of EU health policy as a PDoH. The first dimension captures the policy outputs, consisting of 3 categories. First category is the policy area, where we differentiated across the 3 phases of EU health policy. So phase 1, EU shared competencies anchored in Article 61 of the treaty. Phase 2, that includes EU's internal market and power to regulate. And thirdly, provisions rooted in the monetary union's governance framework. The second category of this first dimension are the health policy objectives in supporting member states, grouped along WHO's 6 building blocks for strengthening health systems. And the third category are the policy instruments, where we consider different types of legislation, policy statements, funding information, and so on and so forth. Second dimension of this framework really was on policy outcomes and puts forward 4 analytical categories that assess how EU health policy outputs can impact health outputs and health outcomes, We've broken these down into 1, the type of effect, so direct or indirect. Secondly, strength of effect, so weak, medium, or strong. Thirdly, scope, broad or rather limited, meaning how many people are potentially affected. And fourthly, the direction of the effect, so did it have a positive or negative impact on health? Very briefly on methods and data, we did our analysis by applying this analytical framework I just introduced on EU documents as a primary data source and on existing research to map the early stage build-up phase of the EHU. We then complemented this policy output-focused perspective with an outcome-based exploration, where we mapped the pathways through which EU health policies may have influenced health outcomes. And again, we did this along the 3 examples of joint procurement, RRF, and European Health Data Space. On the results, and maybe I can pull up just very briefly as quick just point on what we had developed. Yeah, so this is basically what it looks like. I hope you can all see this. No worries, I won't go through all of those categories now, but what I can say is that we found patterns and variations in the expected effect of measures that the EHU put forward on health outcomes. And importantly, this somewhat contrasts with previous assessments of EU health policy research that were exploring rather similar qualities of policy change. As an example now, if we look at the joint vaccine procurement, it was mainly layered on existing governance structures. however, with strong, broad and direct impact on EU citizens' health as a contributor to saving millions of lives across Europe. The Recovery and Resilience Facility, on the other hand, has been a milestone in EU integration. However, health-related impact varies due to the focus on health infrastructure and services, and thus rather indirectly affect citizens' health. We're also seeing a variation in budgets and investments for health reforms in member states and in their implementation. So to wrap up, 2 quick policy implications of our research. One is that this framework, we think, helps make visible to policymakers and researchers the link between EU policy and health outcomes in member states, and really starts to unpack the impact of the former on the latter. And secondly, our findings suggest that the degree of EU health policy integration isn't always reflective of the strength, direction, or effect of policies on population health outcomes. As the case of the joint vaccine procurement has shown, for instance, this impact has been quite substantial and direct. I'll stop right here, and yeah, we welcome any questions and feedback, of course. Thank you.
Thank you very much. Thank you. Let's move on directly to the next speaker, Mary Guy.
Hello. Thank you to Charlotte and Ellie and Thibaud for involving me in this wonderful special issue, and obviously the chance to talk about the paper today. So my paper is entitled Solidarity as a Political Determinant of Health, Insights from EU Competition Policy. And I've just got one slide, which hopefully I will be able to share. Can I ask if you can see that?
Yes.
Okay,
Perfect.
Okay, great stuff. Thank you. So this is the diagram which features in my article. I'm going to be talking around this for the next few minutes or so. So as you can infer from this, perhaps is there's a dynamic between competition on the one hand, solidarity on the other, and between the EU level and the member state level. And so I suppose the diagram is intended to illustrate the extent to which the competition and solidarity axis may move either further up or further down the EU member state level axis. But before really getting into these two dynamics, I wanted to just say a little bit about the role or the function of law as regards political determinants of health, which is something that gets picked up in the paper. So the connection between law and political determinants of health is thought not to be well understood, but nevertheless the two are considered inseparable. So in a sense, law is therefore kind of representing a sort of upstream level within the upstream concept of political determinants of health, with scope for determining other determinants of health, particularly social determinants. Connection between the two can be underscored by findings from other disciplines as well. If we think about competition reforms in healthcare, these are typically seen as quite controversial, but nevertheless there can be insights from fields such as health economics or social policy indicating that competition can either be beneficial or detrimental for health outcomes. Where law comes in is to perhaps sort of entrench a sense of policy direction. And at this upstream level, Mackenbach and Dawes have made the point that there's the need to challenge narratives that health inequities may stem exclusively from social determinants of health rather than political determinants of health. So it's really trying to get more of an insight into these political determinants of health and how they shape matters. The paper explores framings of solidarity as a political determinant of health within EU and national competition regimes, and is framed around the question of whether it can be said rather that either level, the EU level or the member state level, offers quote in quotes better or more equitable conceptualization of solidarity. Certainly there may be competing interests that change and shape the political determinant of health, particularly with regard to the interaction between the EU and member state levels. And we see perhaps slightly differing definitions of solidarity, or certainly different emphases coming out. So with regard to the definitions at the EU level, there has been suggestions from research by DG Santé. Solidarity is defined in terms, is quantified even as 70% of public healthcare system. If there's 70% of the public healthcare system it's thought to be solidarity-based. This is distinct from concepts such as universality and equity as well. So the two dynamics, solidarity is often portrayed as antithetical to competition, and in the case law what we see happening is solidarity forming a kind of buttress against competition and other internal market rules. The argument that there may not be enough competition within a healthcare system to displace the underlying solidarity basis. And in this sense, solidarity is the connecting factor between these different dynamics. It's being described as Tamara Harvey as the ideational point upon which member state healthcare systems converge, and so it sets the parameters for applying competition law. Member state competence in health is defined by Article 168(7). Healthcare system organisation and health policy is a national competence. This comes up against a logic which suggests that competition law applies in a different way. It's determined by the existence of economic activities, which is a functional definition. Nevertheless, the logic that comes through the cases is if a healthcare system is predominantly based on solidarity, competition law does not apply. And we've seen this reaffirmed in recent cases, such as the 2020 judgment in Deruelle about Slovak health insurance, and the 2023 judgment in Casa Regina Apostolorum about the interplay between public and private providers in the Italian healthcare system. So the paper reviews a range of cases within the state aid framework, including relating to services of general economic interest as an exception, and also the Commission's state aid temporary framework mechanism, which relaxed the state aid rules in connection with COVID-19. Distinction between the two dynamics is encapsulated by an anomalous case discussed in the paper called Better Care. This is from about 20 years ago, 2002, thereabouts, which introduced a distinction between internal and external solidarity. Internal being effectively the line taken by EU case law, and external at the time was argued that the approaches taken within the UK were slightly different to this. Nevertheless, as I say, this is proved to be somewhat anomalous to the line the EU continues to take. What we also see is where there are national experiments with competition reforms show that applying competition law isn't a theoretical question in a vacuum. There's a political decision to develop competition in healthcare, and the application of competition law may flow from this. So just to wrap up with a couple of conclusions from the paper. The predominance of solidarity and its function in setting the parameters for the applicability of competition law may well undermine its status as what Dawes calls a determinant of the determinants. But what it does really is to simply clarify that there's a lack of formal competition regulation. And this is distinct from any negative effects which may flow from expanding private sector delivery of public healthcare, or which may shape social and commercial determinants of health. So a quick takeaway would be that determining political determinants of health at a supranational level within this particular context of EU competition law remains elusive, both thanks to the member state competence in health and the line taken by cases, most recently Casa Regina. So I will stop sharing.
Thank you very much, Mary, for this presentation. Matilde is next. Matilde, do you want to? Yeah.
Thank you. I hope everything is working in terms of the setup and you can hear me. And I join in thanking the editors for the amazing support that we received throughout this process. So what I am focusing on is the implication of EU economic governance for national health policies, and specifically looking at the most direct link, that is that of their impact on national health spending. And in doing that, what I'm looking into is the extent to which we can consider the EU economic governance framework and specifically the SGP and excessive deficit procedure as a supranational determinant of health, and especially health inequalities within the Eurozone. And what is the starting point and somewhat the motivation for this analysis is that especially in the context of the pandemic, but also in the previous crisis, we have been discussing extensively on the resilience of the healthcare system and the how this is affected by austerity policies. And if we think of also the country I know best, which is Italy, in the context of the pandemic, there is something that where we had extensive evidence of the vulnerability of the healthcare system being somewhat linked back to the extensive austerity and cost-cutting reforms that were enacted in the previous period. And this echoes back a debate that was quite extensive during the Eurozone crisis and the aftermath. But leaves open quite a big question, which is the extent to which these patterns are something that we can attribute to the EU fiscal framework. And this is the role that then the EU fiscal framework can have as a supranational determinant of health by pushing for the consolidation of health spending. And if this affects different geographical areas in a different way, then also having implication for health inequalities across countries within the Eurozone. So specifically, what I look at is health spending in the member state and in particular in Eurozone countries throughout the life of the SGP until 2018. And this is quite interesting because in principle, the Stability and Growth Pact does not entail a direct intrusion into budgets before the question of fiscal discipline. But in practice, what the analysis shows is that countries that are subject to the excessive deficit procedure display quite distinct patterns. And this is the case both during the crisis and in its aftermath. So even during the crisis, the framework is constraining national health spending, and we do not see essentially any cyclical differences in countries that are under this EPP surveillance, and this is not the case for those that are not within the Eurozone. And after the crisis, we see that countries under the EDP surveillance consolidate spending. And looking at geographical differences, these overall patterns are extensively driven by countries in the southern periphery, which also during the time of the crisis are cutting health spending. So from this, we can see that the excessive deficit procedure does can be seen as a determinant not only of domestic health spending, but also health spending inequalities across countries. And zooming to the pandemic times, if we compare pandemic responses across Eurozone countries, we do see that there is an association between past consolidation, so austerity in this period that that I showed is quite different also in geographical terms, and the stringency of containment measures in the pandemic, which themselves then also not only come with implication for restrictions themselves, but also with economic costs that can then be quite different across country. So coming to the conclusion from this analysis, this shows that even though often the Stability and Growth Pact is considered quite ineffective because compliance is quite low, many countries have even long spells under the excessive deficit procedure, even in a domain such as health, this policy has quite important spillovers that carry implication for inequalities across the Eurozone as well.
Great. Thank you so much, Matilde. Thank you. Right, so I see the program. I'm next, so I'm gonna dive right in. So the paper as I'm gonna talk about is so Simon Rushton and I were interested in this new institution that the European Commission set up in 2021 as part of the European Health Union. So, which is called the Health Emergency Preparedness and Response Authority, so abbreviated HERA. And HERA is an intra-commission service that's tasked with preparing for potential future health threats and respond to health emergencies. And so it's got two modes of operation. One is preparedness mode, the other one is the crisis mode. And so we saw this as a move from the Commission to try and be more involved in governing health. So as an attempt to really further integration in health. And COVID, of course, meant that there was a lot of momentum at that time for this, but at the same time, we know that member states have always been quite reluctant and suspicious when they see that the EU is trying to get more involved in health. So part of our puzzle was to reflect on the extent to which HERA can be seen to represent more integration in health. But in doing so, what we were mainly interested in was to see how the Commission legitimated the creation of HERA in terms of the discourses it crafted around it. So our guiding questions here was first, when the Commission launched HERA, how did it make the case for it? And then secondly, what might that tell us about future EU integration in health? And so our take on the political determinants of health here was really to focus on discursive power and the importance of discourses in shaping the terms of engagement with health issues. So we did a discourse analysis on the documents that the Commission published when it launched HERA, and we were looking specifically at one, how health threats are framed, two, how the added value of EU-level action is justified, and three, how the Commission fits HERA with existing activities and with the treaties. And so we found different framing of health threats. So we found some reference to public health issues. So, health threats as a public health issue, health threats as an economic issue. But mostly what we found was presenting health threats as a security issue. And this is consistent with recent trends globally, but also in the EU, especially over the last 20 years or so, towards securitizing health. And securitizing involves sort of constituting issues that are political as matters of security by constructing them as existential threats. And doing so then enables types of exceptional sort of crisis responses that would normally, that wouldn't be possible in normal times. And security logics were also present in how the Commission talked about the added value of acting at EU level. For example, how it talked about the monitoring and managing of supply chains of medical countermeasures. In terms of legal basis, it's worth mentioning that for the crisis modes, the Commission refers to Article 122 from the TFEU. And here the lawyers will know much more than I do, but our understanding was that this article is also increasingly drawn upon, and it's specifically about exceptional crisis measures justified based on the principle of solidarity between member states. And so we see that the Commission legitimated the creation of HERA by crafting a discourse that reinforces the securitization of health. And HERA's two-mode logic, so the preparedness mode and the crisis mode, is also very much a feature of a securitizing institution. And in terms of what this might say about future EU integration in health, so the paper argues that security was a particularly feasible avenue to for legitimation, which allowed the Commission to kind of build up its power in health governance in the preparedness phase without needing additional competencies, but it also laid the ground for potentially increasing its role whenever the crisis mode will be triggered in the future. And so I guess one of the main takeaway messages is that we wanted to draw attention, and going back to the political determinants of health, is that rather than thinking of HERA whether or not this represents more integration in health, it is useful to look at how do discourses around HERA shape how health issues are understood and how they are governed in turn, and with what implications, not only for how much EU health, but really what kind of EU health. And that's it for me. Let me just immediately move on. Now we have Ashley Fox.
Great, thank you very much. I'm going to attempt to share some slides, but if it does not work, then I will move on and just talk. Let's see. Can you see my slides okay?
Yes, we can, thank you.
Okay, perfect. So the title of our paper is Redistribution Good for Our Health? Examining the macro correlation between welfare generosity and health across EU nations over the last 40 years. So that it's pretty descriptive of what we actually do in the paper, and just acknowledging my colleagues, Lyle Scruggs and Megan Reynolds, who also contributed to this. So the basic premise of the paper, and in terms of how we're situating this in political determinants, is we are thinking of welfare state generosity or welfare state policies as political determinants of health. And so it doesn't fit as neatly into the EU focus of the special issue, but we're looking at it in the context of the last 40 years in which greater integration across countries has occurred. And the question motivating the study was really what accounts for long-run differences in life expectancy and overall health outcomes across high-income countries, particularly European countries. And so this is situated within this large literature on welfare states and health. But even though there is a large existing literature in this area, we think there's a lot of gaps that still remain. For instance, there's been a lot of literature around welfare state regime types, but that's kind of a static conception, whereas the reality is that most countries have a mix of different programs, means tested, social insurance, universal provision, and these have changed. The relative generosity or focus on each has changed over time. Also, there hasn't been as much attention as maybe there should be to whether the effects of welfare states occur in the long run, over, like what time span do they actually have an impact over? Is it sort of short run effects, long run effects, and the mechanisms, how exactly do different types of policies, welfare policies affect health, and do they affect them in different ways? And also, what about other, co-occurring trends like changes in behavioral health and sort of cultural, long run cultural differences across countries? So very briefly, our theoretical conception, what we're sort of trying to add here is this idea that when we think about welfare state generosity, we should think about the mechanisms or the pathways through which different policies might have an effect, including through potentially poverty reduction. That could be one pathway. Redistribution or kind of universality of programs, does it sort of universally benefit everyone, kind of going back to that solidarity conception that we heard about, or is it more through risk protection, so sort of this status preservation mechanism of protecting against income shocks? In terms of the data and approach that we were using, we decided to just focus on life expectancy for this paper, although in the future it'd be great to look at other outcomes. So we looked at this over 40 years across 21 different OECD countries. And then we developed these 5 measures of comparative welfare state entitlements, which are based on some data that Lyle Scruggs has developed, the CWED data that I'll say more about in a second. But these are basically measuring different types of replacement rates, how much these different policies and programs make people whole. And we measure this in different ways, and we control for GDP per capita, health spending, and the obesity rate, as well as smoking rates. And again, we're looking at the period of 1980 to 2018, so a 40-year period across 21 nations. And we take 2 analytical approaches. One is just a sort of simple differencing model where we, subtract life expectancy in 2018 or in 1980 from 2018. And another is a little more sophisticated, using an autoregressive distributive lag model. And these are the 5 measures, but in the interest of time, I won't go into detail about them. You can read about them in the paper. And so basically, to cut to what we find, there's been large variation in life expectancy growth over time, with the US only gaining 5 years and Portugal gaining 10 years. And there's been significant retrenchment in generosity across countries. And our regression results find a consistent positive effect of total generosity. So that's one of our welfare generosity measures. But we don't find consistent effects for our other measures of generosity that were more novel. And we do find, though, that this total generosity was more powerful than other effects like obesity or smoking, and even controlling for GDP per capita and health spending. So just to conclude, we do find a positive effect of total generosity, but we have some suggestions for future studies, such as having more precise measurement of the mechanisms through which these policies are having an effect, and thinking more about the time frame of effects. Is it sort of welfare generosity in early life, midlife, late life? Is it a cohort effect? And also, how much would we have expected life expectancy to improve over these last 40 years, and how do these outcomes compare to that? So I will leave it there, but thank you all very much.
Thank you very much. Thanks, Ashley. Benjamin, you're up next.
I have to figure
I think
out
you're
how to stop
muted.
sharing.
You're muted. Hold on. You're muted, Benjamin.
Yes,
perfect.
I was muted, and I have camera issues as well, but I hope you can see me better than I can see me.
Well, we can still see Ashley's screen, actually, but we can see ourselves, like the Teams window. Perfect. Great. Wonderful. Thanks. I think it's all good now.
Can you see my PowerPoint?
And something's coming up. Yes, if you can maybe just put it in full screen.
Full screen mode?
Yes.
So here it is. Okay, yeah, thanks for this opportunity to present key insights from my paper, which is more a comment titled Checkmating the Nutri-Score, Will Food Patriotism Prevent the Harmonization of Front-of-Pack Labeling Schemes Within the European Union? I think you are familiar with the Nutri-Score. It looks like that. It's a color-coded front-of-pack labeling scheme for food items, and it empowers consumers to compare the nutritional value of prepackaged foods per 100 grams or milliliters quickly and intuitively. And according to the so-called farm to fork strategy, it was the intention by the EU Commission to harmonize front of food pack labeling till the end of 2022. Okay, now it's 2024, and therefore my research question was, why had the EU Commission halted the harmonization process? So the key takeaway or my message is that this has been the case due to very specific set of the political determinants of health within the European Union as a political entity. For most weak decision-making powers in the realm of public health. And these political determinants of health within the EU has been brutally exploited by combined powers of populist governments and the food industry. So the so-called Nutri-Score saga is therefore a prime example of the interference effects between political and commercial determinants of health, or if we like to speak in Giddens terms, it's about the interference between structure and stakeholder agency. And
Benjamin, really quickly, just letting you know that just for like with Mechthild, we can only see the first slide. So I don't know if you want to continue without slides, or if you can find a way to change the way that you're presenting that. Oh yes, okay, you can change. If you change it manually, we can see it. Perfect.
Okay. Can you see this slide?
We see the one called the Nutri-Score Saga.
Yeah, it's not too bad. Okay. So I will continue like that. Okay. Okay. So the question is, so we all know that the EU Commission was able to use labels in tobacco regulation, but it hasn't been able to harmonize the use of labels in front of pack labeling of food items. So, and I argue this, the case for that is lack of political will. And a key argument here is that food patriotism has been pursued, for instance, by the right-wing Italian government, who successfully reframed the discourse about the Nutri-Score by insinuating a vital connection between traditional food products, nutritional quality, and good health. So they capitalized on the Made in Italy narrative. And finally, so as I said, the Nutri-Score Alliance succeeded, unfortunately, by privileging special interests over population health to this specific set of political determinants of health, a weak decision-making structure in the realm of public health. And this went hand in hand with the commercial determinants of health. And so this is the rather sad takeaway of my comment. Thank you.
Thank you very much, Benjamin. Thank you. So we have next up Emilia Szyszowska. Are you ready, Emilia?
Yes, thank you. I'm ready.
Okay.
I will try to put some slides.
Okay, I think if you can just, don't know if you're still sharing, Benjamin.
Give me a second, sorry.
All right.
No problem.
Sorry, I'm a little bit sick.
No, I think
I will
maybe
do my best. Do you see my slides now?
not yet. We can still
Not
see
yet?
Benjamin's slide.
Sorry.
No worries.
Actually.
So I think this should be maybe perfect. Okay, and then Emilia.
Mm-hmm.
Yes, now we can see your slide as well. You might have to again change the slides. Okay, yeah,
manually. Yeah.
Perfect.
Okay. Okay, thank you so much. Welcome everyone. So my name is Emilia Szyszkowska. I'm an assistant at Warsaw School of Economics, and I'm very excited to be here. Thanks for having me today. First, do you remember that film, that movie by Coen Brothers, No Country for Old Men? So Professor Rafal, Riedel, and I, discussing about healthcare system in Poland, we always conclude that this is not a country for a sick man. So this is the title of our short article in this special issue. Why? Because in Poland we have a high level of patient dissatisfaction, poor public funding of a healthcare system, medical shortages, medical personnel shortages, and low health status in general. It's always like the third from the very end of every OECD statistics is Poland, Romania, and Bulgaria, mostly in many dimensions. So many statistics illustrate how weak the Polish system of healthcare is. There is no room to present it today, but my goal with this presentation is to shed some light on the reasons for this, which we believe to be of PDoH nature. So in our analysis, we have applied the mixed methods and we used the material we already had, a little old maybe, but from 2019, because it was a survey exercise created under the multinational Polish-German project on interest groups on healthcare policy in 4 countries of CEE. We conducted this in 2019, and then we repeated. Only me and Rafal, like by ourselves. We repeated this in 2022. So 22. Sorry. So during the course of a pandemic. And the survey was conducted among key interest groups in Poland, which are patients' organizations, employer associations, and employees' side, I mean trade unions and self-governments of health professions. So we have conducted simple descriptive statistics comparing the level of access to main political bodies. We've checked 4 types of political bodies in healthcare, and the analysis was about access of these key stakeholders to these political bodies before and after and during the pandemics. This was supplemented by 15 interviews with stakeholders, and we have conversations not only with the stakeholders, I mean interest groups, which I already mentioned, but also decision makers or even former decision makers responsible for health policy in Poland. And theoretically, we rely on this analytical framework on PDoH, adding some Polish specific. And we do this through institutionalism lenses, applying path dependency approach. So we have identified the late and never-ending reforms, lack of stability in decision-making, corruption, hidden co-payment, and they all arises from the post-communist legacy. So what kind of political determinants drive healthcare policy in Poland? First, it's over-ambitious constitutional rule promising the universal healthcare provision. It was adopted in 1997. And as I said, it promised the universal healthcare coverage for all citizens. As a result, the co-payment is formally forbidden, but due to the long queues, patients need to have private doctor appointments. It's very common here, and this only creates social confusion and dissatisfaction. The second is political competition and party politics, which causes short-termism, lack of strategic planning, and constant changes in the shape of a system. From centralized system under the Szymaczko model during the communism through Bismarckian style health insurances with competition in early 90s and early 2000 year, then public insurance system with no competition, because now we have one main public insurer, and so there's no competition. And up to re-centralization tendencies pushing by right-wing government, which was in power in Poland during the last 8 years. This is some kind overlapped with this private offer by private providers, which, as I said, they overlap the same offer. So this is like a very rare situation, I would say. Underfunding is the third determinant we have identified. So we have a low funding, especially comparing to Polish economic growth in the last years. And underfunding is always political of a political nature, as it is. This is a matter of a political decision, I would say. So this underfunding, the public-private mix, and the strong reliance on out-of-pocket payments is nothing special in the CE region. However, in Poland, the use of additional private sources does not take the form of this voluntary health insurance, but rather direct payments in a system that theoretically offers everything for free for everyone as a universal provision. And the last determinant is poor dialogue with the key stakeholders. We have the survey data, and there is no dialogue tradition or infrastructure. This dialogue is very weak. The tripartite bodies are very weak. And it was, as our survey showed, it was even worse during the pandemic, especially to the regulatory bodies. I'm finishing, which are, I would say, the most important in healthcare at the national level. So to sum up, we argue that the most important determinants appear to be the results of the post-communist legacy, combined with the short-term approach, while implementing key reforms and healthcare interventions. Sorry. Thank you, and sorry for.
Don't apologize. I'm sorry. It's just that so many speakers. It's difficult to stay on track. But perfect, wonderful presentation. Thank you so much.
Thank you.
Okay, so Ellie, do you now have the awesome task of trying to bring everything together with some concluding remarks, and then hopefully we'll still get a bit of time for a few questions from the audience as well. So. Thank you so much let me just say thank you to all the presenters for your wonderful presentation and for keeping on time as well. Thank you.
Absolutely seconded and well chaired, Charlotte. Ideally, we'd all have a sit down and a cup of tea to absorb all of that first, but we don't have that kind of time. So I'm just going to try to really quickly summarize our experience, I guess. So there is an editorial, there's an introductory article where Charlotte and Thibaud and I reflect on some of what's come out of this incredible set of papers. And I don't want to repeat that, but I'm just going to flag two main points in terms of what we felt the strengths of this concept of political determinants were off the back of the work that we've been so lucky to be involved in here. The first of those has to do with black boxing of politics. So we perceived between the three of us a tendency within the existing literature on social determinants and commercial determinants to reach the point where politics becomes an issue and then fail to get into that too much, logically, because political aspects aren't the focus of analysis and that kind of work. They're not the object of the analysis. Where we think political determinants is able to be useful, and what's demonstrated in every single one of these papers is that because a political determinants lens forces us to look at power, whether we approach that as institutional power or structural power or discursively constructed power, or however any of the authors have gone about it, it makes politics and the political the object of analysis, and that enables us to reach so much further than frameworks that focus on other things and just have that as a sort of contextual factor are able to do. So that's the first area, that this idea that a political determinants lens forces us to look at power and thus is able to push us a little bit further is the first contribution that we identify in the editorial. The second is this sense that because we were quite conscious about what a political determinants of health would be, like where it would sit in relation to the models that we already have. The EU focus that we use in the special issue means that the papers are all kind of by default engaging with a multi-level governance framework. And what that has done, by our reading, is help to illustrate what that approach brings to studying the political determinants. And our main takeaway there is that rather than having to understand the political determinants as, if you like, another layer on the social determinants rainbow, so just getting sort of more abstracted away from the individual and their health out to the kind of most outside layer or most upstream layer of the rainbow, what the papers actually do is just by default treat political determinants as a cross-cutting issue, as something that infuses across all of the levels of governance. So rather than us having to bolt it on the outside or have it as an additional pillar in a commercial determinants model or something, it's been really naturally infused as something that cuts across all of those levels, which was an interesting thing for us to discover. And the more we reflected on it, the more we were of the view that that's one of the main values of it as a label. The thing I wanted to close by saying, and that we also talk about in the editorial, is that quite outside of the intellectual or conceptual contribution that we think a political determinants label has, is the advocacy and the policy value of it. So we flag a little bit in the editorial some of our hesitations or concerns about this idea, the kind of deterministic idea of a label that uses that word determinants in and of itself. But we also acknowledge and don't in any way detract from the success of labels like social determinants of health and commercial determinants of health, because they're intuitive, because they do what they say on the tin, because people understand what they're talking about even without having to define it in a super academic way. So one of the things we're most excited about is the potential of this label to be something that engages advocacy and policy audiences and practitioner audiences, and allows us to build a sort of foundation for action, as well as a foundation for a research agenda and a shared scholarly community around this kind of label. I don't want to say too much more than that, because I think most of the fun stuff will come from Q&A, so I'll leave it there. But just to second Charlotte's thanks to Thibaud and to Charlotte, firstly from my side, but also to all of our authors and those that were able to join us and present today. It's really been a privilege for us.
Great. Thank you so much, Ellie. Really wonderfully well wrapped up. So we can take questions from the audience. We have a few more minutes. If you can raise your hands. In the meantime, I'll try and keep an eye. I saw there was already one person who put a question in the chat at the very beginning, and this was about the SDGs. Maybe we can start with this while other people might reflect and come up with questions. But Roger Ceron asked the question, are the SDGs a threat or do they add value to health determinants? So I don't know if anyone wants to, it's a really interesting, really big question. I don't know if anyone wants to have a go at answering that one. Not all together. In the meantime, we can also maybe collect a few questions.
There's one from Brian here about the upcoming Parliament elections. What, if any, impact do you think that will have on the political determinants of health across the EU? I don't know if anybody feels that speaks quite closely to their work. Mechthild comes to my mind, but I don't want to put her on the spot. If anyone feels like the Parliament elections might, what they've studied in their papers might give them something to reflect on that.
Happy to come in on that, on the election question. I can't really say much from the point of view of my paper, because that's really on national politics, and this part of national policy making is not really concerned by European elections, I would say. But speaking about the European Parliament, of course, is my second kind of main research interest, besides the healthcare access of forced migrants and its regulation. I think one reason why this is going to be very much at the focus also of the next months and of the campaign and of the period after the June elections is Ursula von der Leyen herself, who has made a point of standing up for extended health competence in the EU, and who does so also at the national level when she is going around on campaign trips and stuff. So, and her being a trained doctor, etc., if she manages to stay in power, will probably just make the EU even more of an actor and of some, a field of political determination of health, even after the elections, and also again in the election campaign. But since her position has also been quite shaky in recent weeks, it's going to be interesting if we have someone else leading the Commission, if that might change back again to health being much more of a back burner. I don't know, but other than that, I'm not entirely sure how to what else to say about the question. Sorry.
No, I put you on the spot, Mechthild, but that's exactly the sort of expertise I thought you would be able to bring to it. I guess one thing that also comes to mind, a little in relation to Benjamin's paper, but also to mine and Catherine's, has to do with the political agenda. So the Nutri-Score and the front of pack labelling, in addition to a whole raft of other important pieces of public health legislation, went off the agenda in the last year or so because they've been removed because they were deemed too politically sensitive. Essentially, too much time passed and things that they had hoped to do they have not done because they needed to take quote unquote vote losing issues off the table while von der Leyen tries to secure her second term, and while we're looking at this threat of an increasingly right leaning
I think Ellie,
froze.
She froze. Okay.
Maybe I just read Brian's question. I didn't read it before, but maybe if I can add something until Ellie is back. I think what's also interesting when we look at the shift to the right in the EP and the very high likeliness that there's going to be majorities are going to be won on the right part of the European Parliament, and that also von der Leyen herself has been cozying up a lot to right-wing national leaders. I believe that health is going to be much more normativized, in a sense. That's going to be made even more, what we already see a lot at the national level, much more made an identity issue, much more made in something that is more a claim than a right, which we have in right-wing discourses a lot already. And I could imagine this also kind of being uploaded to the EU level even more, what we see already in, and kind of really between my two research areas, in healthcare access for vulnerable groups, for forced migrants, for other groups of migrants who are allowed by EU law to be treated below the level of EU citizens. And I could imagine that we see this even more, that we see these kind of discourses which are now happening at the fringes of politics, much more moving into the focus of EU politics, and that this kind of becomes much more of an issue than it is at the moment. So I think in this sense, shifting majorities in the European Parliament could really play a major role of how how health politics are going on at the EU level. And I feel Eddie's still frozen, I think.
I mean, I'm here. I'm sorry. It's just the most quality technological connection day. I have no idea what's going on, but it sounds like Mechthild wrapped up my point perfectly, as if we're the same person. So no worries.
Okay, great. I just wanted to, so I've had a bit of time to think about this SDG question, and I don't really have an answer per se, but I guess just some ideas that come to my mind in relation to the question. And so what I would say to that one would be around like the politics of defining health. So like whether or not we're categorizing it and trying to like delineate it as something narrow, that sits along, so siloing versus non-siloing. So I think the SDGs, one really great aspect of it is that they are encouraged to be taken into consideration as a whole and not as separate things. But I think ultimately this kind of governance via goals also leads to kind of siloing goals as separate ones. So I think that's kind of like maybe the tension, where on one hand, health is present in everything, like, access to water, education, etc., is all relevant as a health determinant. But I think it depends more on how you define health, whether you take a very sort of biomedical understanding of it or a very holistic one, will depend where you see the intersections between SDGs and health determinants, I think. So it's not really an answer, but it's just some thoughts that I didn't want to leave this question unaddressed. Does anyone else want to add something on either of the questions, or do we have maybe one more question. I know we're running slightly over time, but it was a very packed schedule as well.
There were a couple of comments just about the Polish case. I wonder if Emilia or indeed if Tamara and Alex might like to chip in on this, just conscious of their areas of expertise too.
Yeah, I'm reading them. Fully agree that healthcare politics in Poland is over politicized. We didn't even speak about this reproductive rights, which are also health in a family of health issues. And no, infodemic management, totally agree. But the reaction of a Polish right-wing government to the pandemic, it will be the topic of our next paper, probably because in this paper, in this special issue, we kind of omit this this topic. But yeah, totally agree. And there's also a question on what is the Polish specific, as many of the region, almost all of them, they have this legacy. I would say it's the short-termism. For example, in Czech Republic or even in Hungary, if the reform is undertaken, it's kind of long-lasting. So we can kind of politics decision makers can have this process of learning of this new settlement and somehow adapt to this. And in Poland, it's like a totally opposite reform in every, I would say, few years. So I would say this is the Polish specific, this short termism.
Maybe I can just add something quickly to that, not connected to this paper, but to other things that I worked on. So it's definitely, it definitely has that in common with at least Romania and Bulgaria, and probably a few other cases as well, this constant emergency politics mode of passing legislation and changing legislation with every new government. I think it's also linked to a lot of political instability, so very short terms of governments that they try to quickly push things through. And then some interviews that I did a while back, they were kind of citing this as a reason why they have such short-term legislation, because they know they have 6 months, maybe a year to do something. So I think that's common to a lot of countries in the region.
Mm-hmm.
But I agree that the Czech Republic is one of the better examples.
Okay, great. Thank you so much, Emilia and Alex, for the insights on that. Thank you. I think I see that people have started leaving as well, because it is past the scheduled time. I just wanted to say thank you so much to everyone once again. It's been really a pleasure and an honor to work with you all. Thanks to the attendees for your insightful questions. And yeah, I mean, I'll be posting the recording on the website as soon as possible. And great. Enjoy the rest of your days. Thank you so much. Bye, everybody.
Thank you.
Bye-bye.
Bye.
Thank you.
Thanks,
Bye-bye.
Charlotte.
Bye.
Thank you. Bye.